So today we'd like to discuss the problem of stage 2 colon cancer and how we can best decide on the appropriate therapy for patients who have this stage of colon cancer following surgery. The problem that we have today is with stage 2 colon cancer that many patients are cured with surgery alone, but some percentage, probably around 20% plus minus 5%, are going to recur. So we'd like to really be able to prognosticate better on who needs more aggressive therapy or no therapy. Dr. Nagle, what's your general approach with the stage 2 colon cancer?
So I'll just echo the fact that we find it perplexing because we know that a percentage of patients will recur, and to date we really have not had any good markers, I would say, to help us define who will benefit from chemo and who will not. So far, we've been using additional pathological features like LVI or differentiation to help guide us to patients who might have a worse prognosis and therefore might get the marginal benefit from chemotherapy in stage 2.
Right, and I mean, we try to hang our hats on these kind of weak pathologic nails, but what we find is that there are some stage 2s that behave badly and some that behave quite well, so that's the challenge. Dr. Wheeler, your thoughts about the staging?
Yeah, I agree. I think as pathologists, we're constantly studying different histopathologic features that may help us kind of categorize some of these stage 2 tumors into those that will have a more aggressive behavior. And we're not always able to do so, thinking in particular of things we know as strong prognostic indicators like lymphovascular invasion. We're not very good at identifying it, and I think most pathologists will tell you that when you see a bona fide lymphovascular invasion feature, it's often associated with lymph node metastasis at that time, and of course then you're already out of the stage 2 category. So I think that there are a number of histopathologic features, but whether we can give 100% certainty to our surgery colleagues to know that that is something that you can hang your hat on as far as the way you're going to treat that patient is questionable.
I think the other issue about the histopath features is that when we're together in our hospital in tumor board and we're discussing should we recommend chemo for this patient who's node negative but has these features, time and again the comment comes up that lymph node status trumps everything else. And so the strength of the lymph node positivity is such that we clearly know we go to chemotherapy, and so relative to that, many times people don't feel comfortable recommending chemotherapy, even if there are a host of other histopath features.
Right. I mean, I think the problem in terms of recommending therapy is that there is no definitive clinical trial. It's a little bit like adjuvant therapy of breast cancer before we had the node negative data. To develop that data, we need a much larger study with much longer follow-up, and we just haven't done such a study. In fact, most of the adjuvant trials to date had mix of stage 2 and stage 3. So for stage 2, we're really talking about either T3, T4, and node negative. And we know that even though the overall survival is probably 85%, within that group, we see that with bad features, people may have as high as a 30 to 35% relapse risk. And so the question is still, can we use other factors to help us prognosticate and therefore pick the best adjuvant treatment to guarantee the best outcome?